So, hi, I'm Yiftach, and I'm a medical doctor and electrical engineer at the Sheba Medical Center. I'm currently a researcher at the DEEPVISION lab under the radiology department at Sheba, and I'm going to speak today about our latest research, which is a machine learning model for predicting CT utilization in the ER. So currently there's a paper in submission, and you can see the authors that collaborated in the research. Before I start, I want to say that it's a part of this research was a part of a collaboration that we did with Intuit company, which data scientists from the company came to a 3-day hackathon at Sheba and worked with us on different projects. In this event, we collaborated on, as I said, on different machine learning projects, and some of them got published. I would like to begin by describing the motivation for this research. We all know how much emergency departments are crowded and are, in many cases, the bottleneck in the treatment pipeline. You know that there are numerous attempts to improve and make the process more efficient. One way is prediction tools that allow us to automatically prioritize sorry. So, as I said, to automatically prioritize test, imaging, and treatments to specific patients. We know that head CT is now the most frequently performed CT scan in the ED. So, our objective was to develop a machine learning-based prediction model that will help us to identify the patient that will undergo the exam in the ED. Then we can promote the diagnosis and treatment already in the triage level. For most cases, for a patient to be diagnosed with a brain hemorrhage, for example, the pipeline includes triage, nurse examination, primary medical examination, CT order, CT scan, CT interpretation, medical treatment. We should remember that in extreme cases, hours can pass before a primary medical exam. Hours that can be crucial in case of a headache from brain hemorrhage, for example. So we wanted to evaluate the capabilities of our machine learning to identify the patient in the triage level and help to shorten the process through several actionable steps. We can put the patient in line for the machine before medical exam. We can notify the radiologist of upcoming exam, and thus manpower can be referred. We can also alert the primary physician of an upcoming head CT. In this cohort, we analyzed a large structured tabular database, more than 500,000 patients. It incorporated demographic and clinical details of all the patients admitted to our ED during 5 consecutive years, from 2013 to 2017. Now, data for each patient was acquired from our hospital EMR. And it is important to understand that the features that were taken as input parameters are all data that is available in the triage level. By that, we can use the model, as stated above, to improve ED pipeline prior to the primary medical exam. The features from the current visit include date, time, chief complaint, structured and both unstructured, ESI score that is given by the triage nurse and present the patient urgency. We took all the background data that was available to us, like background diagnosis, chronic drugs, previous visit to the ED, and previous hospitalization. Here we can see that there are patients that undergo head CT in the ED were older in 8 years, but the ESI was almost similar. They had more background diagnosis, the systolic blood pressure was higher, and they underwent more CT scan in the past. The differences can all be attributed to the age difference. Sorry for that. But it should be noted that we analyzed 171 different features, and thus analyzing each feature and its dependencies is hard and exhausting. And we use machine learning models. From analyzing the input data, we can see that the head CT is by far the most abundant CT exam in the ED, and this is the reason we chose it as our prediction target. Now I would like to present the algorithm we've used and its concept. We first need to take a quick look about the basic model that the algorithm we have used is based on, which is the decision tree algorithm. The algorithm breaks down the data into smaller and smaller subsets, and the final result is a tree with the decision nodes and leaf nodes. Now the leaf nodes represent, the leaf nodes represent a classification or decision, and the topmost decision node in the tree is the correspond to the best predictor, and it's called the root node. The next level is a random forest, which create decision trees on randomly selected data samples and get prediction from each tree and select the best solution by means of voting. Finally, the algorithm we have used is gradient boosting, which is also based on decision tree, but in most tests show better performance over the random forest. The gradient boosting algorithm builds trees one at a time, where each new tree helps to correct errors made by previous trained trees. We have used the CatBoost code, which utilize the GPU computing and thus help us to analyze very large data set efficiently. Sorry. In terms of missing values, I want to take a quick look about TROPONIN. Just as an example of how the algorithm treats missing values. TROPONIN we use to identify patients who undergone myocardial infarction. The value is not available for most patients, and that is very significant when trying to predict, for example, patient outcome. Now, giving an arbitrary value to the test, for example, the average, can lead to a significant bias, and so make the value useless. So the algorithm, the CatBoost algorithm, takes none as missing values and use also the none to predict the outcome. Before getting into our results, I would like to explain the metrics we chose. We chose the area under the curve, which represent degree of measure of separability. An excellent model has AUC near 1, and when the AUC is 0.5, it means that the model has no class separation whatsoever. We can see that by changing the threshold, we can increase sensitivity over specificity and vice versa. And now it's a question of our need. For example, we can specify a subgroup of patients that with very high level of confidence need CT scan, and we can try to promote them directly. In such a case, we chose specificity over sensitivity. Now let's get into our results. Before trying to find the best model, we wanted to know the contribution of each feature alone to predicting CT usage in the ED. We can see that chief complaint, both structured and unstructured, can predict pretty good CT usage. Other features have much lower AUC. Now let's check how chief complaint is distributed, and can we really count on it alone? We tried to segment the structured chief complaint to better understand the reason for doing the exam. We can see, for example, that headache is the leading reason for taking the exam. However, only 50% of the patients that arrive to the ED due to headache undergo head CT. In contrast, almost 90% of the patients that arrive to the ED with suspected CVA undergo the exam. And so, although the chief complaint is a very important feature in the decision. There is large variation between different complaints. By applying the CATBoost algorithm on the training set 2013 to 2016 and testing it on 2017, we tested the algorithm on a new consecutive data. We actually derived the model from 4 consecutive years and tested it on a newer data set. The result we got is 0.933. It means that compared to a single feature, we improved the prediction in about 6% by using the entire data set. It may seem small change, but we know that in classification tasks, the last few points are the most important ones and are the hardest to achieve. In the future, we would like to find a subset of patients that need a head CT with a very high PPV. The main limitation of this research are the retrospective trial that was done on consecutive, even though it was done on consecutive years. It is based only on EMR and only in one medical center, but the potential was shown, and now it would be great to evaluate the model on a new recent data from another center. To conclude, we have showed the potential of using a very large data set to predict an important feature in the ED treatment process. It can be used for making the process more efficient, and based on that model and future tuning, we can suggest ways to shorten the time from entry to radiological results. So just in a few short minutes, I want to show you a few projects we are doing in the DEEPVISION lab. Here you can see our founders, Dr. Eyal Klang, Dr. Sheli Sofer, and myself. Maybe even one project I will show you. Another project that we are doing, which is a computer vision project. One of our computer vision projects are the automatic detection of ulcers in a small intestine of Crohn patients that undergone video capsule endoscopy. We can see 2 images. On the left, a normal intestine, and on the right, we can see the pathology. The video capsule exam is very sensitive but very time-consuming for the gastroenterologist. You need to go over the entire movie to get the results. Well, no, just we try to do it fast. I will just to show the results, if the computer will allow me. No, okay. Any questions?